Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening for all speaker, colleague, and attendee. It's my pleasure to introduce the 11 wave of Arab Thyroid Association wave series that organized by Arab Thyroid Association. This is 11 wave, and this session about thyroid nodule. Welcome for all speakers. And if there is any questions, will be dropped to questions and answer or chat, and we will answer it at the end of this wave. Thirdly, we welcome Professor Polin Tchekit, Chief in Antalya Research and Training Hospital Department of Interventional Radiology, Antalya, Turkey. He will present non-surgical thyroid nodule management.
Thank you very much. Now I will begin to share non-surgical thyroid nodule management. I begin. As we know, thyroid thermoablation is the goal is to elevate tissue temperatures in order to create zones of irreversible cellular damage. And afterwards, the created coagulative necrosis is degraded by the patient's own system. In this chart, we can see the mechanism of thermoablation. We use RFA or microwave ablation. We give between 60 and 100 Celsius heat, then occur cytotoxic effect, cell death, coagulative necrosis, and this coagulative necrosis destroyed and phagocytated by the immune system macrophage. And then occur volume reduction rate. But if we give above 100 Celsius, then occur carbonization and it can't phagocytate by macrophage. We use two technologies, radiofrequency ablation and microwave ablation. In radiofrequency ablation, the heating effect of radiofrequency ablation is a combination of frictional and conductive heat. And in radiofrequency ablation units, we use mostly on 18 gauge antennas. Most of them have 7 millimeters active tips, but we have in some companies adjustable antennas. There are between 0.5 and 3 centimeter. In thyroid radiofrequency ablation, we use mostly 50 watts, and all of the antennas have continuous cooling systems. In microwave ablation, they are creating electromagnetic field around the percutaneous antenna and rotating the water molecules in the tissue around their axis 3-4 billion times per second, and kinetic energy and heat consists. In microwave ablation units, we have a 16-17 gauge antennas. The active tip is 3.5, and in thyroid microwave ablation, we use maximum 30 watts in ablation. And all, by the way, in microwave ablation antennas, we have cooling antennas too. What is the advantage of radiofrequency ablation compared to microwave ablation? Mostly the antennas of radiofrequency ablation are thinner, and radiofrequency ablation works according to the tissue impedance. It goes to up to maximum of 800 ohms, and above 800 ohms causes tissue carbonization, and the machine stops automatically. This is a very good protective negative effect on carbonization, and therefore we have a small higher volume reduction result. And we have more experience in thyroid ablation. Thyroid ablation begins with RFA. What is the advantage of microwave ablation? In microwave ablation, we do larger ablated tissue volumes in the same time, optimal heating in cystic nodules, hypervascular nodules, especially in toxic adenomas, less pain during the procedure because we have no ionic current passing through the body as in RFA, and tissue impedance doesn't matter. Therefore, we have no inhibitory effect on preventing carbonization. This is a disadvantage of microwave. And microablation does not require the placement of grounding pads. Therefore, we can use this technology in patients that have pregnancy, pacemakers, joint prostheses, and teeth implant. Selecting the right patients, we have some guidelines. The most important guidelines are two guidelines. One of them are the Korean guidelines, and second is the European guidelines. In the Korean and the Italian guidelines have previously validated thermoablation as the first-line treatment for benign thyroid nodules. And the European Thyroid Association guidelines recommend thermoablation in adult patients with benign thyroid nodule as an alternative option to surgical treatment. In my clinic, we have we do thermoablations since 8 and 9 years. We have 3,500 case series. We do enlarged benign nodules causing cosmetic or symptomatic findings, cystic nodules that contains more than 20% solid components. In this cystic nodules, alcohol ablation recurrence rate are high. In solid and mixed type nodules under 30 cc, because above 30 cc, we need a second season treatment in thermal ablation. In autonomous toxic nodules, growing nodules, recurrent thyroid nodules after previous thyroid surgeries, parathyroid adenomas, in papillary thyroid microcarcinoma, but only in classical variant, and in patients at risk of general anesthesia. We have now a new clinical practice guideline for the use of minimal invasive treatments in malignant thyroid nodules from the European Thyroid Associations. And here are the thermal ablation contraindications in different thyroid carcinoma in suspicion of aggressive subtypes of thyroid carcinoma, tau cell, insular cell, and column cell. In this variant, we don't do thermal ablation. And at the image detection, if the papillary carcinoma have extrathyroidal growth, or if we have multiple neoplastic focus, or if we have presence of lymph node or distant metastasis, we don't do thermal ablation in many cases. Or if we have worrisome molecular pattern, TERT promoter or TP53 mutation, we don't do. Here is a very good chart of this research paper in which cases we do thermal ablation in malignant cases. In young patients, and in papillary carcinoma classical variant, if the papillary microcarcinoma in the central location, if they have well-defined margins and absence of capsular contact, and if it's solitary, in these cases, we do papillary microcarcinoma ablation. Here is a long-term results of thermal ablation of benign thyroid review from Dr. Bayak from Korea. He is the frontier of this technology. And in this paper, if we look to the paper deeply, only one paper of Korea are prospective. The other studies are retrospective. And if we look to the paper, only the paper from Italy, they have only one seasons, use one season in RFA ablation. Otherwise, in the other studies, they use multiple seasons. And if we look to the ablation results, if the nodule size volume between 10 and 15 is, the volume reduction rate is very high, 95, 93, 97. But in the research paper from Spain, Aldea Martinez, in this research study, the volume nodule volumes are high, 36, and this group is the volume reduction rate, 76. But both are very good results. And here's a paper from China. They compare the microwave results in 3 years, and they compare the internal characteristics, solid, predominant solids, and predominant cysts. And in predominant cystic nodules are the results better. And here is the same study. The volume reduction rate approximately between 88 and 90%. And here are study. In this study, they compare RFA and microwaves cosmetic score, and they are the both same results. Risk assessment in thyroid ablation. Therefore, all patients must have normal hormone limits, but in some hypervascular nodules, 5% in toxic adenomas may present as euthyroid. If we have a patient with toxic adenoma, mostly the contralateral thyroid lobe is atrophic, must require a thyroid scintigraphy. And another important situation is, after ablation of hypervascular solid nodules, thyroglobulin and Th, Td4 levels may increase significantly due to the destruction of the follicular cells in the ablation nodule. Therefore, we have a risk of thyrotoxicosis. We must manage the situations. And normally we have the classical is the danger triangle variant. What is danger triangle? Danger triangle describes the area between the esophagus and the trachea and the medial portion of the thyroid gland. But now we use the danger zones concept. What is this? Because we have many variation of some anatomical structures, and the danger zone is between the medial part of the thyroid gland and the jugular vein. Before ablation, we must do a very good anatomical evaluation. Firstly, we must found the nervus vagus. The nervus vagus is on the lateral side of the thyroid gland in the carotid artery sheath. Normally, it is on the 3 o'clock or on the 12 o'clock position, but sometimes it has some variations. It is on 10 or 6 o'clock. If the nervus vagus close to the thyroid nodule, then we can have thyroid thermal injuries. Another anatomical variation is the middle sympathetic ganglion. Normally, it is on the lateral side of the carotid artery, but sometimes it is between carotid artery and thyroid gland. Here is an example. This is the thyroid nodule. Here we see the carotid artery, and here we see the middle sympathetic ganglion. If we have thermal injury in middle sympathetic ganglion, then occur Horner syndrome. And here is one of my cases, damage of the cervical sympathetic chain, and then occur Horner syndrome. Another important thing is in every cases at the ablation or after the ablation, we look to the laryngeal ultrasound to the vocal cords. Here we see right vocal cord paralysis after thermal damage. You see that the right vocal cord don't move, but the left vocal cord moves very well. And here are normal patients. Both vocal cords are very have good movements. It is very effective method, laryngeal ultrasound, and very easy to learn. At the ablation, we have some voice changes. Most of them are the lidocaine effect because we give 10 cc lidocaine under the thyroid, between the thyroid capsule and strap muscle, and this occurs sometimes terminant 1 hour voice change. Sometimes, if we have recurrent laryngeal thermal injury, then we see voice changes. If we have voice changes, or if we have some symptoms of Horner syndrome, we must use this two mixture. It is 10-20 cc cold dextrose and 20 milligram methylprednisolone. We inject this directly to the tracheoesophageal groove, and of the cold effect of the cold dextrose and of the anti-inflammatory effect of the methylprednisolone, the symptoms resolves in 5 minutes. And before ablation, we must make an anatomical risk assessment. We must look to the position of the thyroid nodule, and if between the thyroid nodule and the anatomical structure less than 2 millimeters, if we see less than 2 millimeter thyroid parenchyma, we must use hydrodissection. And what can we use for hydrodissection? We use normally crystalline liquids, dextrose, or saline, but we cannot use for hydrodissection saline RFA because it has an ionization effect. Therefore, we use in every case dextrose. To control pain, before we give between the strap muscle and thyroid capsule, we inject 10 or 20 cc local anesthesia, lidocaine or prilocaine, it is not important. This make a peripheral anesthesia. And here is an example by this video. We go with the needle between the strap muscle and the thyroid capsule and inject lidocaine. Mostly I don't change the needle, I only change the hub. Then I inject here dextrose between the carotid artery and thyroid nodule to make a hydrodissection area. Here is another example. We have a right parathyroid adenoma, and the parathormone is 142. It is a very high level. The right parathyroid adenoma is close to the tracheoesophageal groove and close to the carotid artery. It is on a very dangerous location. Before we go with a needle perpendicular directly here and inject here dextrose and separate them, the parathyroid adenoma from the carotid artery. Then I navigate the needle under the parathyroid adenoma and push here more dextrose to make here a hydrodissection area between the tracheoesophageal groove and parathyroid. Second option is you can use the lateral approach and push here more dextrose to make here a safe zone. After that is the ablation very easy. We entry the parathyroid adenoma with the antenna and begin to ablate it, and the ablation procedure is only between 5 and 10 seconds. Which nodules are the best candidates for thyroid ablation? In which nodule are the volume reduction rate, the shrinkage rate best? the best candidates are the spongiform ecostrictors nodules, spongiform nodules. Second, nodules with liquid component, nodules with high intense peripheral and intranodal pattern vascularity, or the second is very important. I use shear wave elastography in my clinic, and we measure every nodule before ablation, and soft nodules have better volume reduction rates. Here are some technical factors that affect the volume reduction rate. Most are in microwave, we must use low watts between 20 and 30 watts. Second is ablation of the peripheral margins of the thyroid nodule is very important because the most regrowth points of the nodules are here. Therefore, we must use in every ablation hydrodissection for better ablation of the nodule margins. And here are the formula of the volume reduction rate. The treatment goal is minimum 50%, but in the clinical practice, it must be minimum 70%. And as we know, volume reduction rate is higher in cystic nodules than solid nodules. And the volume reduction rate increases as the elastography volume decreases. We have a new research paper, and in this research paper, we found that if we measure the shear wave elastography value above 60 kilopascal, the volume reduction rate is less than 50%, and in these cases, we don't do thermal ablation. Moving shot technique. We begin with a needle from the posterior inferior aspect of the thyroid nodule, and if you see the bubbles, this means this is Kuhl's cytoplasma. This means that the follicular cells of the thyroid nodules are destructive. We move slightly back. Go. This is the moving shot technique. And here is a nodule. Before ablation, it is 5.4 ml. After 1 month, we don't see any significant difference between of the volume, but only the echogenicity is more decreased. But after 3 months, it's go to 3.75 ml, and after 1 year, it is under 1 ml. And here are another video. It is spongiform nodule. Before the ablation, I go with the needle under the strap muscle between the thyroid capsule and strap muscle and give here lidocaine. Second step is I go with the needle between the carotid artery and thyroid nodule, and I push there dextrose. Then we begin to ablation. If I see the bubbles, I go back, and this is the moving shot technique. Here, another case. I go with the needle here. I push here dextrose, make a safe hydrodissection area. In the lateral part, we see here the nervus vagus. Then we begin here to the ablation with the posterior inferior part. If I see the bubbles, we go slowly with the needle back. We divide the thyroid nodule like an apple in 3 dimensions. Firstly, we begin the posterior, then the middle and the anterior part of the thyroid nodule. And this is a toxic adenoma. As we see, this is very hypervascular. After ablation, we don't see any vascularity. And here are the ablation process. Before the patient, thyroid stimulant hormone was debrided, but only after 1 week, the thyroid stimulant hormone is on the normal level without radioactive iodine therapy. And here is another patient. She have a high parathyroid hormone, and the calcium is high, and the parathyroid hormone was very big. It was the biggest parathyroid adenoma that I treated. It was 4 centimeter length, 3 centimeters. And here we see the inferior thyroid artery and the polar artery. I try with the needle between the carotid and jugular vein, and then I reach the posterior part, and we give here some hydrodissection. And now we have here hydrodissection area, and then we begin with the needle ablated with the moonshot technique from the posterior to the anterior and from inferior to superior here. And this is before ablation, and this is after ablation. All the parathyroid adenoma are restricted, and after ablation we don't see any vascularity because it is very important. We don't see the polar artery. We must ablate the polar artery. And after ablation, I control with laryngeal ultrasound to vocal cords. We have no vocal cord paralysis. And in this chart, we see before it was 100 13, but only after 2 weeks it's go to 25. The parathormone is totally treated. Another important thing, after thyroid ablation, the morphologic structure change. The ecogenic are decreased and the nodule go more stiff. And now we have a new term in thyroid classification. This is thyroid PT. It's mean thyroid post-therapeutic. We described every nodule after ablation in the thyroid classification. And here are another research paper from China. It is a very frequently question from the clinicians and from the patients. Have we any histopathology changes after microwave or radiofrequency ablation? And they do 69 core needle biopsy tissue sample after ablations, after 60 patients. And what they found is, in newly patients, they only found freshly ablated thyroid tissue, they only found it coagulate degeneration, but necrosis occur after 6 months. What means is, this means that the total process ended after 6 months. If we think that we must do a second session for ablation, we must minimum wait 6 months, and after necrosis, the procedure are stopping. Here is another research paper from Korea, and in this they research, does radiofrequency ablation induce neoplastic changes after ablations, and they do core biopsy in 16 benign thyroid nodules, and they don't found any atypical cells or neoplastic transformations. They found only acellular hyalinization in the specimens. And this is a patient from the literature. He have a liquid-rich nodule, 85 ml, and after 3 months, it's go to 7 ml. This is my patients, both my patients. She have 165 cc multinodular goiter. I treat these patients in 2 sessions, and after that, volume reduction rate is 79. And this is a young needle. She have a 32 cc spongiform nodule. After 3 months, it is go to 4 cc, and the volume reduction rate is 88%. This is a patient. She have 90 cc right-sided spongiform nodule. After 3 months, it's go to 3.5 cc, and the volume reduction rate is 96. In this patient, we have very good results. And this patient is from Nigeria. She's an animator in the hotels in Antalya. She have a 156 cc big nodule, and after 4 months, it's go to 21 cc, and we have a volume reduction rate approximately 86. And here we see the conventional surgical treatment disadvantage: hemiorthotal, high risk of hypothyroidism, risk of hypoparathyroidism. Sometimes they have more high risk in laryngeal nerve defect, cosmetic problems, and infection. And here are the advantages of thyroid ablation. First is the thyroid gland is protected. Patients do not need lifelong thyroid replacement therapy, no incision scars on the skin. It is an outpatient procedure. We only use mostly only local anesthesia, and the patient is discharged after 2 hours. It is very minimal invasive. And here we have 2 pictures after thyroidectomy, and this is only after thyroid ablation. We only use 1 needle hole. I will tell another important new treatment method in thyroid patients. We use this since 3 years. It is thyroid artery embolization. We have between 100-150 case series. As we know, the thyroid gland have 4 feeding arteries. There are right inferior thyroid arteries. And in some cases, in plongeon goiter or in thyroid nodules or thyroid glands that involves the mediastinum, the surgery cannot operate these patients. We embolize these patients. They come to us. We in the angiogram, we go with the catheters and found this is mediastinal growing big thyroid lobe, and then we gave some small microparticles and embolize them. And this big lobe shrinkage rate, volume reduction rate is after 3 months 80 or 90%. And in some other important thing is, Sometimes in the thyroid lobe, they have some innominate artery variation. Here is a joint space. The pyramidal and isthmic lobe have some feeding variations. If this patient have operations at the section of the superingular lingular nerve at the operation have a bleeding risk, we embolize this patients with microspheres. And this is my hospital. It's research and training hospital in Antalya. We have 1,600, 700 beds and approximately 1,200 doctors. Thank you for listening.
Thank you for your elegant and informative talk. Now we will move to the next speaker, Dr. Salman Al-Safran. He is endocrine and general surgery assistant professor of surgery, Kuwait University. It's a recorded talk about updated surgical skills in benign thyroid nodule.
Good evening, everyone. My name is Salman Al-Safran. I'm an assistant professor of surgery at Kuwait University, chief of endocrine surgery at Jabir Al-Ahmed Hospital, Kuwait. We'll be talking about updated surgical skills in benign thyroid nodules. To start, I would like to thank the Arab Thyroid Association for the opportunity to present. I have nothing to disclose. First, thyroid surgery. How old is thyroid surgery? Although goiter has been an endemic in several parts of the world throughout history, the first recorded goiter excision did not happen until the 500 AD by Abu al-Qasim in Baghdad. Despite postoperative bleeding, the patient survived. The second recorded goiter excision was done in 1950 AD by Abu al-Qasim in Europe, where he recorded his surgical experience and technique by his surgical tome Al-Tasrif. The well-known and described thyroid surgery was performed in the school of Salerno in the 1200 AD by Roger Frugadi. During his surgery was very cruel surgery. The patient was awake, was held by an assistant, and two heated iron cetone were placed through the neck, through the goiter, and they were tied gradually to excise the thyroid. So this picture here and the screen left, you can see the Madonna of Coronation that was painted by the famous Leonardo da Vinci. And if you pay a closer look at the picture and the neck, and you can see there's a mild goiter that he actually described it or painted it. And the screen right, this is basically the description of the thyroid surgery that's done by the School of Salerno by Frugadi. Again, you can see the patient is awake, held by an assistant, and the two heated cetone through the goiter. When we talk about nowadays or modern thyroid surgery, we cannot forget the father of the thyroid surgery. We have Theodore Billroth. Theodore Billroth, he was very well regarded and very well distinguished surgeons in the 19th century. His initial surgical result for thyroidectomy was plagued by very high mortality, up to 40%. 8 of the 20 patients that he performed thyroidectomy on had a mortality, died, and most of the result of the death happened because of infection. He basically, after this result, he stopped doing thyroid surgery, and later on during his surgical career, resumed doing surgery with a much lower mortality of 8%. The second of the thyroid surgeon, we can't forget about Theodore Kohar. He's actually the founder or the developer of the current technique that we use to this day of the thyroid surgery. Just imagine back in his days with almost no instrument, he performed a very safe thyroid surgery, and he had a very low mortality of less than 1%. He is one of the only 5 surgeons to ever receive a Nobel Prize in 1909, and he was giving the Nobel Prize because of his work in thyroid surgery and the pathophysiology of thyroid. The current incision that we do for thyroid is named after him, and is the same incision that he used during his surgery. And he had a famous quote, said, "A surgeon is a doctor who can operate and who knows when not to do." We can't forget his contribution to the hypothyroidism. Theodore Kocher performed a total thyroidectomy and an 11 years old girl by the name of Maria. 8 years later, he noticed she did not grow. So the picture here, the one on the left, you can see Maria, that's the taller girl. And then 8 years later, on the right-hand side, you can see her younger sister had outgrown her. Because of this, he completely stopped doing total thyroidectomy, and he was doing only partial or subtotal thyroidectomy. Next in the line for the thyroid surgery and the contribution to the thyroid surgery is William Halstead. He's one of the students of Kocher. He described the parathyroid vascular anatomy, and he had a famous say, which conclude by the supreme trump of a surgeon art. What he meant to say, to be regarded as a good surgeon, you should be able to do a thyroid surgery with no mortality. The next in the line is the 3 surgeons, Charles Mayo, George Cryle, and Frank Leahy. And those surgeons are well-known surgeons, and they are well-known because of their ability to do a very safe thyroid surgery. We know that Charles Mayo, he's the founder of Mayo Clinic, George Cryle, founder of Cleveland Clinic, and Frank Leahy of the Leahy Clinic. So most of the advancement in thyroid surgery today is secondary to many things. Most importantly is the use of anesthesia and the use of antiseptic. Looking at the picture back from Kocher, he did the surgery with no mask, bare hand, and you can see and early mortality were secondary to infection, and also to the surgical instrument and the energy device. We have better retraction, we have better surgical instrument, we have diathermy, we have bipolar, and nowadays we have advanced hemostatic device. And recently, or not recently, we also been utilizing the intraoperative neuromonitoring during the thyroid surgery. Today, most of the thyroid surgeon will do sutureless and drainless thyroidectomy, thanks to multiple devices. Out of those devices, the 2 famous ones, the bipolar sealant device, one of the companies is the LigaSure, and the ultrasonic scalpel, the harmonic scalpel. So going back to the surgical concern during the development of thyroid surgery, in the 19th century, the main concern were infection and bleeding. And once those were under control, other things in the 20th century came into an effect, which is hypoparathyroidism, injury to the recurrent laryngeal nerve, and hypothyroidism. In the early 21st century, incision or cosmesis is the concern. Nowadays, we can do a very safe surgery. The concern shifted from a safe surgery into cosmetic surgery. This is some of the incisions that were described in the literature, and you can see they have multiple. By no means this is the only incision. There is multiple other incisions that's been made, and in the screen right you can see this is the Kocher incision, and most of the thyroid surgery are now done through this Kocher incision. Even with the Kocher incision, you can see the incision pretty large, pretty ugly, and even when we do very small incision, still people who are prone to develop keloid or hypertrophic scar will not have a satisfactory result. So surgeons have to think of outside the box and come up with a minimal invasive thyroidectomy. This has been done through different multiple ways, making the incision smaller through a 2 to 3 centimeter neck incision, using a video-assisted thyroidectomy, or doing no neck incision, rather having a hidden scar, either from a remote access or a complete scarless or a node surgery. Of those, this minimal invasive video-assisted thyroidectomy was popularized in Europe by Micheli in Italy. He's performed a number of surgeries, and he had a very comparable complication rate and time. He was able to do his thyroid lobectomy in a median time of 32 minutes and a total thyroidectomy in a 44 minute. Next in the line is the other remote access thyroidectomy. You can do it through the axilla, which is called a transaxillary thyroidectomy, or bilateral axillo-breast approach thyroidectomy. They did not gain a lot of popularity worldwide, still used in Asia, mainly Japan and Korea. But as you can see, require a lot of skills, require a lot of time, and associated with much higher complication rate. Then we have what's now called the transoral thyroidectomy. Thanks to Ankun Anawang, I actually spent some time with him back in 2018 to learn this technique. And out of all of those, this is the only true natural orifices transluminar surgery, because with this technique, you completely have no visible scar. You go through the mouth, and he described his technique and published his work and his first 400 cases. Only had a 3 conversion to open surgery. His operative time was significantly closer to the open technique, and his complication rate was similar to the open technique. The surprising thing, you would think going through the mouth, you would develop an infection. In his paper, he had absolutely 0 infection rate. So this technique has gained much popularity and is, when I was during my fellowship, there's like a few in the United States, and now almost a majority of the endocrine surgeon that perform this technique in the States, and a lot of places in Europe. So to qualify for this technique, there is some indication. Some of those indications, the patient should have a history of hypertrophic scar or bad scarring. The patient has to be motivated to avoid a neck scar. The maximum thyroid diameter should be less than 10, and if there is a dominant nodule, should be less than 6 centimeter, with one of the following criteria: benign lesion, multinodular goiter, or indeterminate nodule, or thyroid carcinoma less than 2 centimeter. The contraindication for this technique is having previous neck surgery, history of neck radiation, large thyroid with retrosternal extension, cancer of more than 2 centimeter, or pathologically enlarged lymph node, or if the patient has coagulopathy. To address, to see what are the eligibility of the patient that we see as an endocrine surgeon, we did this multicentric study where we examined all comers, like 1,000 consecutive patients that presented to endocrine surgery practice. When we dug deep into the eligibility, we found for benign disease, up to 70% of the patients with benign thyroid surgery would actually qualify for this transoral endoscopic surgery. Next, this is a paper that we published for the first 5 cases that we performed in Kuwait. And as you can see, we had a very low complication rate, only 1 temporary mental nerve injury, and a patient who had a seroma that we had to aspirate twice. Next, this is a video showing one of the cases that we performed. Those are the site of the incision. This is the vestibular approach. With the electrocautery, we make an incision in the inner aspect. This is after placement of the 3 port. This is the patient and where we are standing. As with open surgery, we start with developing a sublatissimal flap. Screen top is basically the skin and the subcutaneous tissue. Skin bottom is the strap muscle. After doing the flap, we divide the strap muscle at the median raphe using, again, electrocautery. Once this is done, the muscle is retracted laterally and exposing the underlying thyroid. Then we use a retraction stitch to retract the muscle away and to completely separate the thyroid from the strap muscle. Once this is complete, we divide the isthmus of the thyroid to expose the underlying trachea. And as you can see, the white thing is the trachea. Then we turn our attention to the upper pole vessels. Those are the upper pole vessels of the right thyroid lobe. Those are divided. And as you can see in the process, here, the white structure across is the external branch of the superior laryngeal nerve. Then we completed division of the upper pole vessels. Then we medialize or turn the thyroid medially and divide berry ligaments. This is the white structure. This is the right recurrent laryngeal nerve. Then we divide berry ligament, which is the attachment of the thyroid to the trachea. And this is completed. Then the thyroid lobe placed in the bag and removed through the mouth incision. When this is done, we do a final check to check for any bleeding. And as you can see, the white structure here, this is the nerve, completely intact. Then we approximate the strap muscle. And this is the final result of the closure. This is our patient, 3-week post-op. As you can see, there is no scar. She's happy. So in conclusion, although the basic thyroid operation has not changed much in the last 100 years, technical and technological advancement have improved our ability to prevent complications and modified our approach to thyroid gland. With this, I would like to thank you and thank the Arab Thyroid Association for the opportunity to present.
Thank you, Dr. Salman, for this elegant talk. And now we will move to the last talk in this wave. Dr. Iman Al-Siddiqui, Division of Endocrinology Medicine Department, Sheikh Khalifa Medical City, Abu Dhabi, United Arab Emirates. And here talk about updates in the clinical management of thyroid nodule.
Thank you, Dr. Ghada, and good evening, good afternoon, everyone. So I'm going to shed lights on some of the updates onto the management of thyroid nodules. So may you allow me to control the screen, Ziad, please?
You are controlling, Doctor.
Okay, how do we move into the next slide? Okay, perfect. So I'm going to start addressing the causes and the factors behind formation of thyroid nodules. We will be talking about the epidemiology in the population, affecting which group of gender, age. And I'm going to talk about also the risk of malignancy given in thyroid nodule. And we will present the Bethesda system. This system is a structured system to aid in decision-making. So we will present also different applications to judge what suspicious nodules are needed for final aspiration biopsy, and what would be the approach and management options. Next, please. So age, if we talk about risk factors, so nodule formation increases with age. The thyroid nodule presenting in a child, however, the thyroid nodule presenting in a child carries twice risk of cancer as compared to the adults. And age above 60 and below 30 are ages with higher cancer formation in a given nodule compared in other age groups. Now, male gender tends to have twice risk of cancer in a thyroid nodule compared to females. A previous history of head and neck irradiation or a thymic enlargement in children is associated with an increased risk of thyroid nodularity and cancer. So therefore, if you have a child presenting with enlarged thymus, we usually detect that on images. So if you perform, ultrasound, or you perform CT scans for non-thyroid related reasons, so for example, upper respiratory or symptoms that are resembling striders in kids, and you find thymus, you need to investigate that. So you need to perform a detailed ultrasound and follow that thymus enlargement. Now, non-thyroid cancer survivals, kids with especially hematological malignancies or hematopoietic stem cell transplantations who have received a lot of therapies and a lot of CT scans, which is a form of irradiation, prior to the age of 10, in other studies prior to the age of 14, carries a higher risk of cancer formation and nodule formation. Next, please. Now, if it comes to the size, thyroid cancer appears more common in nodules above centimeter, from 2 to 4 centimeter. So nodules above 4 centimeter has lower risk of having thyroid cancer compared to nodules from 2 to 4 centimeter. That is because nodules above 4 centimeter tends to be present in populations of multinodular goiter in certain geographical distribution. So if you have a long-standing history of multinodular goiter and very large sizes, a couple of them, that presentation, even with the presence of coarse calcification, that presentation tends to have less cancer tendency. However, based on the size and based on the other suspicious features, this nodule needs to go through a final aspiration biopsy. Now, that's an interesting fact. Proportion of follicular cancers increased from 6 to 16% as nodules increased from under 2 to over 4 centimeter. So the type of thyroid cancer would be follicular cancer in this type, as compared to the most common rate of thyroid cancer, which is papillary thyroid cancer. Next. So a presentation of thyroid nodule, what would be the cause behind that? So it could be either a benign cause or a malignant cause. Most common benign presentation would be multinodular goiter disease or Hashimoto's thyroiditis. So there's a difference between these two most common presentations. So Hashimoto's thyroiditis might present with either single or multiple nodules. So Hashimoto's thyroiditis is the first presentation of what's called overt hypothyroidism in the future. Multinodular goiter disease could be an anatomical presentation or a problem, a disease, without having a functional disease like Hashimoto's thyroiditis. Now, cyst formation, either a colloid, a simple, or a hemorrhagic cyst in a previously colloid cyst, can present in young females. You know, we do find this presentation in an acute manner. Follicular adenoma and NIFTIP. NIFTIP is a new entity that has been termed by major pathological authorities. So NIFTIP does not carry the mortality risk for conventional thyroid cancer. So NIFTIP on its own does not need what we do for thyroid cancer. It's a benign thyroid disease. However, if left not resected along the course of presentation, it could lead to the very early stage of cancer, papillary thyroid cancer. Moving on to the malignant causes, you know, the regular ones, papillary, follicular, medullary, anaplastic ones. So based on the presentation, you can suspect. What would confirm that is histology. Next, please. Next. Okay, other factors, other modifiable factors. So smoking. So smoking increases the risk of any nodule formation and any growth in the body, not just the thyroid. Iodine deficiency, certain people in a given geographical distribution would be presenting with what's called multinodular goiter disease in an iodine deficient area. Obesity plays the role of smoking. So obesity doesn't cause thyroid nodule on its own. It does through inducing inflammatory factors. Apart from causing thyroid nodule formation, it does induce other growth formation like adrenal nodules or other cystic formations in the liver or kidney. Alcohol consumption has been found to be associated with increased risk of thyroid nodule formation, more so in women. The IGF-1 level would cause any growth formation, including thyroid nodules. However, the use of oral contraceptive pills and statins have been associated with the decreased formation of thyroid nodule. There's a recent study that statin could be used in treating Graves' disease. So based on the previous studies, these are, previous epidemiological retrospective studies, observational studies, which found statins association with less formation of thyroid nodules. From there, many other higher quality studies were conducted and could possibly recommend the use of statins in Graves' disease. Next. So how do we evaluate the thyroid nodule? Our aim is to exclude thyroid cancer and to deal with symptoms. But our first aim is the need to exclude thyroid cancer is a must. The rate of thyroid cancer given in any thyroid nodule ranges from 4 to 6.5%. Higher in other parts of the world, especially in iodine deficient areas. Now, we have conducted a study by our group and found that the risk of thyroid cancer and thyroid nodules in our tertiary institutions was around 8%. So higher than what I'm presenting, higher than North American rates, but lower than some parts of Europe, or some parts in Europe. Now, a nodule presenting in children would carry higher chances of that nodule being a thyroid cancer. So therefore, a nodule presenting in a child, we should take that very seriously and investigate. So adults less than the age of 30, children, as we said, patients with a previous history of head and neck irradiation, patients with a family history of thyroid cancer, especially first-degree family history. Once they have reported a higher incidence of a higher rate of thyroid cancer in adults over 60 years. However, other studies did not reproduce the same concept. Next, please. So how do we risk stratify the nodule into further approach and management? So we perform ultrasound. Based on the ultrasound, we tend to choose the nodule for FNA. And before that, we need to perform non-procedural risk stratification, that is by history physical. So in history, you take a detailed history, especially if you have a family history of thyroid cancer. It tends to run into families of syndromic features. So if you have a familial thyroid cancer, that could be categorized into either a non-syndromic or a syndromic. If you're talking about syndromes, so there is a familial non-syndromic non-medullary thyroid cancer, and most of that type would be papillary thyroid cancer. Syndromes associated with that type would be familial adenomatous polyposis or Cowden syndrome, P10 hamartoma tumor syndrome, or Dicer-1. For familial medullary thyroid cancer, other presentations you need to examine for is MEN2A and MEN2B. Now, on physical exam, you need to examine the nodule. If you find a fixed nodule, a hard nodule, or associated with dysphonia or cervical lymphadenopathy, you need to consider a higher risk in terms of stratification and get that nodule for FNA. We will talk about molecular testing during the FNA procedure. Next. Okay, so the first thing we do is to perform, to see whether this nodule is functional or not. So we perform a TSH level. So a TSH level that is normal or high, you go ahead and perform the ultrasound. If the TSH level was low, less than normal, then you perform an uptake and scan. The uptake and scan, along with the subnormal TSH, you perform free T3, free T4. The uptake and scan could tell whether this is a subclinical hyperthyroidism, where in this case you observe unless associated with other features, or overt hyperthyroidism by the presence of high free hormones. So in that case, you treat that nodule and you do not FNA that nodule. You do not FNA that nodule until you treat that nodule. So when do we perform the ultrasound? If the TSH was normal or high. Now with a high TSH level, some people would go and perform the uptake and scan and they would find a cold nodule. And then that will click into their mind that this nodule, a cold nodule, is cancer. We don't use that approach. Always go by this protocol and perform ultrasound. So ultrasound, based on the ultrasound feature, you will decide whether this nodule needs an FNA or not. Next, please. So it's called the neck ultrasound. It should be a high resolution ultrasound, and it helps select the nodule for FNA, final aspiration biopsy. So how do we categorize the risk of malignancy based on the ultrasound? There are more than one application predicting the malignancy risk, and I'm sure most of you would use either one of those I'm going to presenting. Next, please. So in general, before going into presenting the applications, ultrasonographic features that are associated with an increased risk of thyroid cancer: hypoechogenicity, solid composition, solid versus cystic. So if it was a cystic, that goes against malignancy. Microcalcifications as opposed to macrocalcifications. Irregular margins and infiltration. A nodule being taller than wide. And suspicious lymphadenopathy. Based on the number of these suspicious features, you perform the FNA procedure. So now I'm going to present apps that would help you decide when to biopsy the nodule. Next. So we'll move onto the first one, the American College Radiology TIRADS classification. Our colleagues in radiology use that application, that scoring system. So they study these suspicious features I have presented, and they give points for each suspicious features, points plus the risk of malignancy. And then they recommend you when to biopsy. Above 2.5 centimeter, above 1.5 centimeter, or above 1 centimeter. So that is used mainly by our radiology colleagues. Next, please. The most used ones by endocrinologists who perform final aspiration biopsy would use this one. Now, recently, some of the endocrinologists have turned into using the TIRADS system for scoring, and we'll present the pros and cons for each system. But that has been there for long. So highly suspicious features are hypochoric nodule plus the presence of one of the followings that I have mentioned previously. So microcalcification, infiltration, and so on. So that gives a risk of malignancy, a stated risk of malignancy, and it tells you a recommendation of performing a final aspiration biopsy above 1 centimeter. And you have an intermediate risk and low suspicious risk. Now, totally benign, which carries a very low risk of malignancy, we do not biopsy. And in the case of purely cystic nodule, we do not perform biopsy in a purely cystic nodule unless if it was a therapeutic aspiration. So we do send that for examination, but if it comes out as Bethesda 1, do not be surprised. There is no malignancy if it comes as Bethesda 1. Next. There is a more structured one, which is the ACE, published in 2016, similar to the ATA guidelines for scoring thyroid nodule for risk of malignancy. So a low risk, an intermediate, and a high risk would tell you when to biopsy and what are the associated features. Next. These are some of the sonographic features of high-risk nodule. So marked hypoechogenicity, as you see, infiltration, calcification, and invasiveness, the presence of suspicious lymphadenopathy and calcification in this case. Next. So if we come to judge the first one and appraise the first one, which is the TIRADS system, it is more selective and more complex, a more structured one, more selective. What do we mean by that? So if you follow the TIRADS, it would reduce the number of biopsies done and improve the accuracy. In a meta-analysis of 12 studies and over 18,000 nodules, it was superior to the approach taken by the American Thyroid Association guidelines in terms of specificity and being more selective. And hence, you avoid performing other biopsies, which are, in their opinion, not needed. Next, please. So here's a comparison among the most used ones in our world, in the Arab world. Now, the first one is a Korean one, Korean TIRADS, similar to the ATA. But if you appraise all these three common ones used in the Arab world, the ACE was very specific. The potential spared final aspiration biopsies were over 2,000. So by performing the ACE criteria, you would avoid performing that number of biopsies in a given nodules during the study as compared to the ATA. So ATA, in other words, is more sensitive. The ACE was the most specific. So which one would you adapt? It actually depends on the rate of cancer harboring in a thyroid nodule in your population. So you cannot say one of them is correct. I'm going to follow one. You need to calculate the risk of malignancy in your institution. If your institution's risk of malignancy in a given thyroid nodule was above 20%, then you definitely need to use the ATA, which is very sensitive. And it depends on other factors as well. How clean the surgery is, how patients are adherent to the follow-ups. Based on these three factors, you choose whether you do a specific application ultrasound criteria technology or a sensitive one. Next. So as we said, the sensitivity is more with the ATA and the Korean one. They're very similar in terms of applying the criteria. And the ACE was the most specific ones. And with that, more spared FNA is found if you use a more specific application system. So ACE tends to be used, and we recommend the use of ACE criteria in ultrasound scoring if you have a rate of malignancy in a thyroid nodule that is not very high, and you have good surgeons that would do a clean surgery, patients coming back to adhere for follow-ups and monitoring and surveillance. Next. So based on that meta-analysis, the TIRADS, the American College of Radiology TIRADS and the ACE were providing the most accuracy in terms of sparing cytology, considering the rate of malignancy in those populations studied in these meta-analyses are less than 20%. Next. So after you perform the ultrasound, what do you do? Based on the ultrasound, you choose your nodule, whether you want to go for FNA or observe for follow-up surveillance ultrasound. Let me introduce the Bethesda system score here. That will, that's a score also given to a final aspiration biopsy findings, cytological findings. So Bethesda scoring of 5 or 6 are suspicious for malignancy and malignant. If your pathologist terms your nodule following FNA being either 5 or 6, the risk of malignancy is above 75%. And for Bethesda 1 means simply it's a non-satisfactory sample. It's different from Bethesda 3. I see people mixing up these two terms. Bethesda 3 does not mean that the sample is unsatisfactory. It simply means that some cells of atypia features were found in the cytology. Next, please. So I've introduced the Bethesda system. There is a subcategory. I'm not sure if all endocrinologists are using this thing or not. So if you encounter Bethesda 3, which is atypia, it's sometimes hard to know what to do about next. So you go and perform what's called subclassification. You go back and ask your pathologist, does that atypia, what kind of atypia is it? Is it architectural atypia or nuclear atypia? So architectural atypia, so they go back and study further the cytology's finding. If the atypia was of an architectural type, then that nodule tends to be a benign nodule. However, if there were more nuclear features or oncocytic features in that Bethesda 3 category, that nodule tends to be more malignant. And therefore, so based on that information alone, you can decide whether to go for surgery or observe by a follow-up ultrasound if you have not performed molecular tests. So we'll talk about molecular tests, but what we used to do in the past before the surge of publications related to molecular testing, we used to perform surgery for Bethesda 4, 5, and 6. So for Bethesda 5, either lobectomy or total, but for 5 and 6, we used to do total thyroidectomy. Now for Bethesda 3, again, some would send for surgery or perform a follow-up ultrasound. We base our decision based on further information from pathology, as we said, subclassification, or ultrasonographic features. We go back and look at the ultrasound if there were associated features, suspicious features or not. So that's what we do in our institution. For Bethesda 3, we do not send for surgery. We do not follow up, without any guidance or criteria. We follow the ultrasound criteria for the presence of further suspicious features, or we perform, plus we perform the subclassification. So we take all these information together to aid the decision. Another piece of information which is important, the family history, the presence of positive family history or of an examination, as we mentioned, a hard nodule in certain geographical distribution, like people exposed to environmental radiation. Some we have found presenting with hard nodule turning to have thyroid cancer. So all these information would up the risk of cancer and guide you to send for surgery. Next. So what we used to do in the past, based on this recommendation published in 2017, is for Bethesda 4, 5, and 6, we perform surgery. So what do we do for Bethesda 3, where the malignancy risk is only 15%, you either send for surgery or repeat an FNA. I have mentioned in my previous slide what factors aid in the decision to send either for surgery or repeat an FNA. Next. So that is the same thing, a recommendation published by Valderrabano and McIver. So for atypia or Bethesda 3, you rely on sonographic features. We also rely on further subclassification of atypia and history and physical exam, whether to do a diagnostic surgery. So in this case, remember, it's a diagnostic surgery. It's not a therapeutic surgery because you do not know what this Bethesda type 3 will turn into. Or you repeat an FNA. We do not observe and follow by ultrasound unless the patient does not want to repeat FNA. Okay. Next, please. So management option, we have spoken about, you send surgery, lobectomy versus total. The next few slides will tell us the extent of surgery. How do we decide whether to perform lobectomy or total? Repeat an FNA. Ultrasound follow-up, we do not recommend unless the patient does not want to repeat the FNA. So all these will risk stratify further in order to send for surgery or not. Next. So this is a study by our group here. Since we are a tertiary hospital, we get more referrals for more suspicious nodules, and 50% of our practice for Bethesda 3 goes to surgery. We base this on the sonographic features, further classification of atypia. Next. So let me introduce molecular testing. The aim for molecular test is to rule out malignancy. And to do that, the test has to have a very high sensitivity and a negative predictive value. So a high sensitivity and a negative predictive value are needed in an excellent test in order to rule out malignancy. High positive predictive value needed to rule in malignancy. That's a secondary aim, but the primary aim is to rule out malignancy. So in a population with a prevalence of 20 to 40% thyroid nodule, again, you base these test criteria based on the rate of thyroid cancer formation in a given in nodules. So the negative predictive value of 94% and a sensitivity of over 90% are required in a test to rule out malignancy. Next. These are some of the updates in the most used molecular tests. So let's talk about the Thyroid version 3. The version 3 is the most updated one. It utilizes the next generation sequencing technique to evaluate over 100 thyroid-related genes. So it tests for point mutations, fusions, copy number alterations, and gene expression alterations. So that test is very good in pediatrics. If you're performing an FNA in pediatrics and wanting to know the risk of malignancy in a given nodule. That test has improved because it does use DNA and RNA-based analyses, and the reports are being expressed as negative and positive in addition to providing mutational details. It does have a sensitivity of 94% and a negative predictive value of 97%. So excellent numbers. Next, please. What about the Afirma gene sequencing classifier? We used to have the Afirma gene expression classifier, but this is an updated version of that old one. It still does report the results as benign or suspicious, so in a binary result, and it does not give further information or details about the genetic details. It does have an excellent negative predictive value, 90%, a sensitivity of 91% only. It has improved because it has used the RNA expression-based analyses, which has improved its sensitivity. Next. There is this test, which is called the Thygene Next Thera-MIRE, which stands for micro RNA. This test is superior to the previous two ones I have presented. It does analyze RNA, DNA, genetic mutations, plus microRNA gene expression classifier system. So by that, you're covering all possible factors responsible for this signal transduction pathway in the tumor formation, in cancer formation in thyroid. Its positive predictive value has increased. That is to rule in malignancy, but our aim, as we said, is to rule out malignancy. So it does have a negative predictive value of 97% and a sensitivity of 95%. Next. So after you have performed FNA and if the molecular analysis is available, that will guide either to perform surgery, you send for surgery, or you follow up. But what are the other indications for surgery apart from cancer? It's compression. So the presence of compressive symptoms like dysphagia, mainly people who present with dysphagia, difficulty in breathing while turning, while lying on one side, and functional thyroid nodule will tend to be cured with surgery versus thionamide. But you need to stabilize first before you send the patient to surgery. We have talked about cancer. We do have different approaches for atypia. Remember that molecular testing aids in decision-making. It is not available in most parts of the world. Even in some parts of the world, it's not being highly applied in all the practices in that part of the world. Also, patient's input is important. If patient tells you that I'm going to be anxious for the rest of my life, performing follow-up surveillance on that thyroid, suspicious thyroid nodule, let me, I'd better take it out, then that could aid in the decision, especially if, with an anxious patient or a patient tends not to follow up, adhere to follow-ups. Cosmetic causes, again, surgery could be indicated for cosmetic causes. However, we do have other alternative therapies like subtypes of thermal ablation and ethanol ablation. With that, I conclude my talk, and thanks for joining.
Many thanks, Professor Iman, for this illustrative and excellent talk. If there is any question, Mr. Ziad.
Doctor, we have two questions, question answers.
Answer? Yes. Okay, I have questions for Professor Poland about the microwave ablation of thyroid nodule. Firstly, I wanted to ask the period of monitoring after microwave ablation. You said in presentation 6 months. We do histopathology or follow-up, and then after that.
Yes, the follow-up presented, we call the patients in the first 1, 3, and 6 months. The most volume reduction rate is in this period, but sometimes we call the patients after 1 year. But the first 6 months are the most important points, and my experience is the most volume reduction rate is in the first 3 months.
And I want to ask about what is the criteria of failed microwave ablation, and then refer the patient for surgical removal.
If the patient have multiple nodules, because we cannot treat in one session 5, 6 nodules, but if the patient have 1 nodules or 2 nodules, big nodules, and if we have after the biopsy benign results, and we have no any contraindication to do. Only in multiple nodules we don't do it because it's not effective. It is a very long procedure in these cases.
Okay, we depend only on the result of 1 FNA for the nodule, or need 2 FNA document this is nodule is benign for do microwave ablation.
Yes, normally they say 2 FNA before, but in my clinic we need FNA in the last 1 month. 1 FNA in the last 1 month.
Okay, thank you very much. Thank you.
Yes.
Professor Iman, I want to ask about the Bethesda system classification and Thyroid classification. In many ultrasound, we found that the classification of nodule Thyroid 4 or 5, and when we do FNA, the result is Bethesda 2. As regards this, return to the Thyroid classification and refer patient for surgical intervention, or wait for 1 year as regard to the guideline, and do another FNA for this patient?
Excellent, excellent question, because this actually confuses many endocrinologists. So therefore, you need to pick, that's why I'm following the ATA guidelines. If the Bethesda cytology reports a benign Bethesda 2, which is a benign cytology, we have to believe that and repeat the ultrasound in a year, not the biopsy in a year, the ultrasound in a year. And based on the ultrasound, if there is a size criteria change or further suspicious features, you perform an FNA.
Okay, there is one question for you, Professor Iman. So to clarify what I get about Bethesda 3, we should get back to pathologist regarding the nuclear criteria, and for radiologist regarding structural criteria, then tumor risk factor that help the patient could have like history or previous radiation. This is maybe the comment.
The question is answering itself. So based on these things that have mentioned, we use to decide what to do with the Bethesda 3. So as the person who have asked, the presence of suspicious features on ultrasound, or go back and ask the pathologist for the presence of nuclear or oncocytic features, or history, irradiation, hard on exam, family history, first degree relative, I would send for surgery.
There is one question for you, Professor Boland. Who is the best candidate for thermal ablation, and is it included in the guideline?
Yes, now it's included in the European guidelines. The best candidates are, firstly, we have some criteria. The first important criteria is the stiffness of the thyroid nodules. Soft nodules have better volume reduction rates. Therefore, the best type of nodules are the spongiform nodules. Second is nodules with high intense vascularity, have a good results. And the another important criteria is nodules under 10 cc. This means if the nodule is above 4 or 5 centimeters, these nodules need a second season in 6 months. Therefore, we have 3 important criteria. One is the stiffness of the nodule, and the most soft nodules are leakage rich and spongiform nodules. Second is the volume of the nodule and the vascularity. This type of nodules are the best candidates for thyroid thermal ablation.
Okay, there is another question about is thermal ablation the same as radiofrequency ablation?
Yes, radiofrequency ablation and microwave ablation have the same effect. The effect is a heat effect. We give between 60 and 100 Celsius heat to the nodule, and we use in both technology the moving shot technique. It's the same technique.
Question for you, Professor Iman. Who should manage thyroid nodule and to whom I should refer?
It depends where do you practice. So in the United Arab Emirates, the one who manages thyroid nodule, we have two school of thoughts, either an ENT surgeon or a general surgeon who does thyroid surgeries, or the endocrinologist. Usually surgeons would refer to endocrinologists. People who are trained in North America, the practice there is that endocrinologists would manage the thyroid nodule, and endocrinologists would dictate the extent of surgery for the surgeons.
Okay, there is another question for you. What is the practical use of NGS in thyroid nodule, the cost effectiveness?
Yeah. Now, first of all, it's not covered. Even in North America, it is not covered by insurance, regular insurance. It does cost $5,000. In our country, it's not covered as well. Without the genetic testing, we know what to do with that thyroid nodule. There are guidelines. There is a set approach to deal with Bethesda 3, 4, 5, and 6. I wouldn't say it would change the practice unless the patient does not want surgery. So I see the best application for the genetic testing is in Bethesda 3 and 4. Where you're really not sure, because for 5 and 6, you know what to do. You need to refer to surgery where the histology will confirm the cytology. But for 3 and 4, it's not correlated totally. So that's why the 8 molecular test comes in place. But we also have other criteria to rely on to aid, like sonographic features, as we said, oncocytic presentation, that will correlate more with cancer. And you do not need the molecular test in this case to aid your or to guide your decision making.
Okay, thank you, Dr. Iman. And there is no questions more. Is there one question? This is a question for you, Professor Boland. What is the optimum size for ablation?
The optimum size is 4 centimeters. Normally, we follow up not with size, we follow up the nodules with volume. And the best ablation candidates for The best candidates for thermal ablation is under 10 cc. Therefore, optimal volume is under 10 cc. And this means approximately 3 centimeter, 4 centimeter nodules.
Okay. Dr. Iman, you mentioned in presentation that thyroid cancer is more in thyroid nodule more than 2 centimeters, and it is likely if more than 4 centimeters. There is a comment for you that there is a reported cases with thyroid cancer less than 1 centimeter. What about your opinion?
So now before you, so how was cancer diagnosed in those patients below 1 centimeter? By surgery. If the nodule before surgery, we need to do an FNA. I know some parts of the world, they do not, sometimes they do not perform FNA, they take the patient directly to surgery. That is not practiced in other parts of the world. So it depends. That paper you are talking about, where was that paper published from? Usually for less than 1 centimeter, you decide whether to do FNA or not. Now, with the presence of 2 suspicious features, if it's less than 1 centimeter, I would biopsy. But if there is 1 suspicious feature, we would wait. Yes, there are case reports or some series of cancer found in less than 1 centimeter, but the recommendation usually when it comes out, it does not measure its outcomes based on few series. It does measure its outcome on large population-based studies on many nodules and the recommendation by proper practice.
Okay, and as you regard to do FNA if have 2 suspicious criteria and size of nodule less than 1 centimeter.
Yeah.
Okay.
Now in children, I do see kids as well with the thyroid nodule and thyroid cancer. I get a lot of referrals for children with less than 1 centimeter and microcalcification. In this case, we need to be very careful and do closer follow-ups for these kids, frequent ultrasounds and do detailed history because the formation of thyroid nodule in kids is not common in certain parts of the world. Now, if it was iodine deficiency, yeah, we can understand that it could be a common presentation. However, it would be less common than that in adults. But dig into the history and just see why that child has formed thyroid nodule. Either there would be a presence of family history of Hashimoto's or examine for syndromes, check for radiation. Hidden radiation, we get, lots of kids with exposure to X-rays, CT scans, that plays a role in nodule formation with calcification.
Okay. For referral for the surgery and the decision for lobectomy or total thyroidectomy, the endocrinologist who decides this or surgeon?
Yeah, good question. So in our institution, the endocrinologist decides that. So that's called deciding the extent of surgery. How do we base our decision? How do we base the decision to send for either lobectomy or total thyroidectomy? Now for Bethesda 5 and 6, we recommend total. Definitely for follicular, Bethesda 4, we do lobectomy. We do not have molecular testing in our institution to aid whether to do lobectomy or total. So for Bethesda 4, we perform lobectomy. For 5 and 6, we perform total. Now, for Bethesda 5, sometimes see if the nodule was less than 1 centimeter, no presence of cervical lymphadenopathy, unilateral, no involvement of the contralateral lobe. Some institutions would perform Hemi with close follow-ups. So it's fine to perform Hemi. And if the histology turns out to be cancer, it's fine because the tendency for having cancer on the contralateral lobe is very low. If you do not have lymphadenopathy, so lymphatic spread, or extra thyroidal extension, or invasiveness on ultrasound, invasive to the recurrent laryngeal, or invasion into the muscular structure, or spiky invasiveness of the thyroid nodule itself. But we do not perform that in our institution. We tend to do total thyroidectomy.
Okay, there is a rule for systemic therapy for huge goiter resected for medullary thyroid carcinoma with negative RET and high initial calcitonin. There is a question also.
So the question is to perform systemic therapy medullary thyroid cancer, right? Is that the question?
For operated huge completely resected medullary thyroid cancer with negative RET and high initial calcitonin, any rule for systemic therapy and how to follow?
Yeah, so when to start systemic therapy for medullary thyroid cancer? Before you start any systemic therapy, you need to make sure that there is no resectable disease. Very high calcitonin tells you that there is a cancer somewhere. So you perform a high resolution neck ultrasound, and in most of the cases, you will find nothing in the neck. You need to examine the liver. So you perform your CT, the whole body, images. It would be seeding in the liver, but it won't show up. So if you do not find any evidence of structural disease on images, even if the calcitonin is very high, you cannot start your systemic therapy, because the criteria to start a systemic therapy is that you need to have a disease burden. You need to show or demonstrate a significant increase in volume, which is more than 20% according to the RECIST criteria. That burden has to cause symptoms, either diarrhea that is unbearable, compressive symptoms, mainly these two, or life-threatening compressive symptoms. You have to start the systemic therapy, but without structural findings, you cannot start systemic therapy. So very high calcitonin, you need to dig into where that medullary thyroid cancer is seeding from.
Okay, the last question for Professor Poland regarding microwave and thermal ablation practice. Is it done by a radiologist or a skilled endocrinologist?
Also, this method is developed by intervention radiologists from Korea, Professor Bayak. But in the world, in different countries, different specialists do this procedure. In Italy, most of the doctors are endocrinologists that perform thermal ablation, or surgeons. In Latin America, most of them are head and neck surgeons. In Korea and in Turkey, most of intervention radiologists. My opinion is, which doctor have the best results, he can perform this. It is only with the skills. If the doctor has experience, if he perform his learning curve, I have given, I think, 20 or 25 workshops, and most of them are attended endocrinologists and surgeons from different countries. And if they learn and have enough skills to do this, they can do it. It's not problem. Important is the results of the what we do, safe and good results in the patients and good patient selections.
Okay, at the end of this wave, I am thankful for Professor Imam, Professor Poland, and Professor Salman for elegant talk and interesting discussion. Hope for more waves organized by Arab Thyroid Association. And I invite all attendees to join our annual conference, will be held at 26-27 May 2023. And thank you for all.
Thank
Thank
you.
you. Thank you.
Thank you.